There is a saying known as nunca es tarde para aprender. Yeah, it might look like I'm speaking in Greek or Latin, but actually it's a Spanish proverb which says that it's never too late to learn. So, as our, I'm very humbled that, and I'm honored that I'm being hosting today's session. So, first of all, before the session starts, let me welcome you all. Warm welcome to all the National Working Committee members of IHMA, state and district chapter members of IHMA, the senior doctors, and these enthusiastic participants. Before we go into session, first let us start with the remembrance of our master, Dr. Samuel Hahnemann. Let us pay some tribute to him. Okay, thank you. So today's topic is about menopause transition, homeopathic management, a basic protocol. And the speaker of this today's program is Dr. Khushali Gambhir. Let me introduce the doctor in brief. Dr. Khushali P. Gambhir had been practicing homeopathy in Chennai for more than 20 years. Apart from studying menstrual disorders for post-graduation, she's also a globally acclaimed expert in treating pediatric, gynecological, endocrine, orthopedic disorders, as well as undiagnosed rare conditions. Dr. Khushali's homeopathic clinic first opened its doors in 1996, and in its last 25 years, the team has grown to accommodate an able set of doctors and administrative staff. The clinic has created opportunities for women from all types of educational backgrounds and walks of life. And about her presentation and publications, has presented papers in both national and international conferences. The Indian Menopause Society Lucknow has acknowledged her paper, Homeopathy for Menopause. Some of her other presentations are Successful Homeopathic Management of Benign Menstrual Disorders, Clinical Tips, What and Why, First Aid in Homeopathy for Women's Disorders. And she's a founder member of Dr. Kopika's Foundation for Homeopathy. She's the member of Roundtable Homeopathy India, member of Indian Menopause Society, and she's also a member of our Indian Homeopathic Medical Association. She's also to be known as trained in mental health first aid, which is to be known as the first batch to be trained in Chennai. And she's also a member of Liga Medicorum Homeopathica Internationalis. She's also a founder of this charitable clinic for women for 2 years through Dr. Kopika's Foundation for Homeopathy. And lastly, if there is any queries from the participant side, please put your queries in your chat box. We will be discussing your queries at last after the end of the session. Lastly, I would like to quote something like Après la pluie le beau temps. Again, this is a French quote, which means after the rain comes the sunshine. And this unwanted, brief explanation of this welcome rain, I hope there will be a sunshine of glorious sunshine of wisdom and learning from Dr. Khushali, ma'am. Ma'am, please.
Thank you, Dr. Mahideen. Shall we go ahead and start, or?
Yeah, ma'am, please.
Yeah.
You can.
Okay. Just spare me a little bit help on sharing the screens, right? One moment.
Yeah, sure, sure.
All right. Okay. So good afternoon, everybody, and I'm always very privileged to speak for IHMA. I'm very fond of IHMA and the great work that they do. And none other than a lovely Sunday afternoon for me to speak on my favorite subject. And thank you all for being here. And I love the Spanish and the French, Dr. Mahideen. Thank you. I've just been watching Lupin, which is a French Netflix series, and wanted to learn French actually. So today we will speak on homeopathic management of menopause transition. So menopause has been a subject that many people are treating. It's just a different, one more viewpoint, not a different viewpoint, just different thought processes. Many head to the same subject for the simple reason is 50% of the population is anyways going to go through it at some point or the other. And some will go through it with certain intensities, some will go through it with milder intensities. And hence, I am very fond of this particular subject because I do get a lot of patients, and midlife itself started catching my attention to a great extent. So the first thought process came for the necessity of a protocol for menopause transition. And the need for the same came in because we all know that menopause is associated, it is the loss of fertility, yes, but it is not just the loss of fertility. More important, it is the onset of aging and non-communicable disorders. So by definition, menopause is 12 months of 12 consecutive months of amenorrhea. And the menopause transition, or what we call the climacteric phase, has a multitude of symptoms, some of which are functional and some have genuine advanced pathology. What we have seen is a mixed bag over here. It is a mixed bag of miasms, but predominantly psoric manifestations are characteristic because of the hypersensitivity associated with this particular phase. Lifestyle and environment play a huge role in the evolution and the maintenance of the symptoms through this whole period of menopause transition. Menopause can cause a lot of distress, both miasmatic and non-miasmatic. And if it is left untreated, the symptoms can become really bad. So friends, what was very interesting in this is it is a different experience for every woman. And for the same woman, each month can be a different experience through the whole transition period. The menopause transition period technically starts anywhere between 40 to 60. So that is the years of midlife. Now, a protocol can be the method which should be followed to basically control a certain disease. So this is very important, that right in the early stage, this polluted soil needs to be rectified. It needs to be addressed with anti-miasmatic treatment so that there is a trouble-free transition. Menopause per se is not a disease. It is a phase of a woman's life which is definitely going to come through. So whether it comes naturally or surgically, it is going to come. So a person has to transit through it very safely because it is the onset or the gateway of non-communicable diseases. So what was the aims and objectives? I did this study surely out of curiosity in my clinic, and then this was presented in Italy. And what was the aims? The first aspect was to evaluate the scope and the limitations of creating a protocol for menopause transition. Why? Because this was a phase with high variability of symptoms and a lot of sufferings. A quick intervention was needed through few drugs capable of covering most symptoms and concomitants. And also, this is a phase where some important parameters need to be checked, and their progress has to be checked through homeopathy. Some of these parameters were like endometrial thickness, the stress, insomnia, vasomotor flushes. All these come in early in menopause transition. So some of the most important parameters that we keep a check on, literally on day-to-day in the clinical practices, going by the Indian Menopause Society's guidelines, the endometrial thickness for a premenopausal woman is less than 5 mm, and a postmenopausal woman is 4 mm. In this span of irregularity of the menstrual cycles, in the span of irregularity and waxing and waning of the hormones, there can be conditions like PCOS that comes up, ovarian cyst that comes up, cervical erosions, hypertension, diabetes. Like I already mentioned, it is the gateway. It is the gateway to non-communicable diseases. When I say while the gateway is open through the whole of midlife, not only through to women in menopausal state, but to men also at this same period of midlife. hypothyroidism, metabolic syndromes, obesity, mental health for women, the breast health. It is very important to prevent anemia at this stage, so bleeding needs to be kept under check. Urogenital health is of paramount importance because of the stress and urge incontinence that can come up for a woman, especially with multiple pregnancies, episiotomies which have not been taken care of, if they've not been exercising well, hemorrhoids, fissure in anal, leukorrhea, vulval itching. Bone health is a very important state here. Women are very prone to osteoporosis, and it is definitely important to keep vigilant in prevention of injuries. Again, I would highlight this fact that menopause has got my attention for the simple reason is it is not just end of fertility, but there's much more to it. So what really made me come to the concepts of creating this protocol? None other than now. This is the best time. Really, when I was working on this paper, genus epidemicus was there, no doubt. But today we know genus epidemicus. We talk about genus epidemicus, and everyone knows it in and out thoroughly. So, genus epidemicus and concomitants. Now, aphorisms 101 and 102 speak of the acutes. The genus epidemicus, what we discuss of today in the pandemic. But when you read aphorisms 103 and 104, they basically talk of an insight on the collective phenomenon of a disease and SORA, and identifying the homeopathic drugs for the same. So SORA was identified from different people, different individuals, very many individuals who presented some portions of the disease. And that's how the whole gamut of SORA was identified. And so also, and that's what I would like to highlight in aphorism 103 and 104. Concomitants, again, concomitants are characteristic symptoms. We're all aware of what concomitants really are. And in this, mental symptoms are the best concomitants, more so if they're newly present. Please understand, at menopause transition, there are a lot of newly presented symptoms. So once again, protocol formation. The combination of aphorism 103 from Organon and concomitants. The Indian Menopause Society has their clinical practice guidelines, in which they state vasomotor, urogenital symptoms, menstrual irregularities are all linked with estrogen levels. But here's a list: muscle and joint pains, vertigo, palpitations, paresthesia, mood changes, depression, insomnia, nervousness, formication, decline in sexuality, and trust me, friends, many, many more. These are associated with menopause, but do not correlate to estrogen levels. So let's see how much information we get at this phase. The biology and symptomatology of menopause is genuinely blurred because it has a relationship to the underlying aging process. So in a nutshell, friends, this is a phase where new symptoms are present. Mental symptoms will be widely present in this, and they make very good concomitants. The aphorism 103, which spoke of SORA, has a wide range of symptoms and seen over a large number of individual cases, and that has a large range of medicines to help these. Menopause transition also is a wide variety of symptoms, and each becomes a concomitant to the other. The intensity of the symptoms qualifies it. Like I said a little bit earlier, friends, every woman will go through a variety of symptoms. For the same woman, each month can be different. And for different women, it is a different set. So it is a lot of collective information that we gather at this particular phase of life. So to highlight some of the materials, methods, and the limitations of this little study that I did, It was done in my own clinic in Chennai. The number of cases were 150 cases were selected at random to identify the common presentations seen in my clinic. It all started with really this one sentence: what am I actually seeing in the menopause transition in my clinic? As I said, there was a wide variety of symptoms, but in a private clinic, in a residential area, what am I really seeing? There were predominantly 5 presentations. So we took 30 cases further, selected at random for the 5 most commonly presenting conditions through the transition phase. The inclusion criteria was women at the age of 40 to 60 years, which is the years of midlife. Exclusion criteria is patients with suspicious or confirmed malignancies. Observation was the cases were followed up 30 to 60 days, once in 30 to 60 days, and usually for a period of 10 follow-ups. Wherever possible, investigations have been done, and they were done to confirm normal pathology, abnormal pathology. Diet and regimen, I do spend a lot of time explaining the diet and regimen to women and educate them the importance of good diet, good lifestyle, sunshine, sleep, and just lifestyle. There were limitations to this study. Like I said, it was just done out of curiosity to assess the most frequent presentations of menopause and their response to a group of remedies. There was no control group. Some patients did not follow up with investigations. Some patients wished to discontinue the treatment once their presenting complaints were better. This predominantly happens when it comes to menorrhagia. Standardized questionnaires were not used for all cases. I'm going to run through a series of 4 cases. I have changed the names and made it a standardized XX so that we can upload this in YouTube. So the first case, Mrs. XX, 52 years, she presented with hot flushes. Mind you, she was 52 years at this point. She came to me in March 2017. Her chief complaints were hot flushes, palpitations, and followed by sudden coldness and perspiration, especially around the waist and below. And yes, very irritable when the hot flushes came on. Since 2 years, she had irregular menstruation. Her last menstrual cycle before she met me was on 25th of January 2017. She met me in March 2017. Her sleep has been disturbed due to the frequent night micturition. Apart from this, there was bloating, weight gain, hyperlipidemia. She was already on statins when she met me. Nothing much in her family history. Mother went through a hysterectomy. Thermally, she was hot. Her mind was very anxious on small things, very restless, always in a hurry, angry. She won't express, will bottle up and brood. This patient had a very interesting follow-up. In March 2017, she was given Amyl Nitrosum for a month. Because she was 52 years of age, I asked her to do her basic ultrasound, and her endometrial thickness on 17th of March was 3 mm, well within the safe zone. So she was given on March 2017, she was given Amyl Nitrosum 30 twice a day. And this is what happened. On 13th of April, she developed a menstrual cycle, and then there were no hot flushes. Thereafter, she came back in August 2017 with hot flushes, burning. She was better the previous time, so I just continued Amyl Nitrosum. And September, she got a menstrual cycle and no hot flushes. In January, again, she came back, hot flushes. Here, she did not know whether she did get a cycle in October or not. Nevertheless, Amyl Nitrosum was given to her once again. In January, 2nd January, she met me. 22nd of January, she developed her menstrual cycle, followed by no hot flushes. I must tell you, she was 52 years old I was concerned, but this endometrial thickness of 3 mm was keeping it going. In July 2018, hot flushes again and palpitations. She was now undergoing a lot of stress because of a family wedding and her own son's wedding coming up. Her sleep was poor. She was treated with amyl nitrosum for 5 months continuously. Her hot flushes were better but not gone. Till in September, she developed a menstrual cycle, followed by no hot flushes. Thereafter, in February again, she came back. February 2019, hot flushes increased and insomnia was tremendous. Once again, I gave her amyl nitrosum 30. This time, her hot flushes were better, but there was no menstrual cycle. On March 30th, 2019, she came back. Her hot flushes and sleep were better. However, she was depressed and she kept wanting to cry. At that point, I gave her Pulsatilla 30 twice a day for a month. Please note, again, same woman with a change of symptom through a different phase of the menopause transition. She had no further hot flushes. Her last menstrual cycle was 7-9. I am sorry, my just give me a moment. I'll have to switch off my whatever that echo or home echo. It's hearing menopause too much. So much for gadgets listening to you. So she had no further hot flushes, and her last menstrual cycle was September 2018. Again, we needed to do her ultrasound just to check. Her gynac did it, and I asked her to do it. Endometrial thickness was 2 mm, pap smear, mammogram, all normal. Uterus was 5.3 by 4.2, 2.5 centimeters, all within the normal limits. So this lady was transited through a normal menopause. These are some of the references for amyl nitrosum. It was just simple on HomePad. Just when I typed it, I was surprised to see amyl nitrosum actually. And it was since it was a small remedy, it was a curiosity prescription and it worked. It was very interesting to see how the follow-ups developed. Amyl nitrosum has beautiful references in Boric and also in the keynote redline symptoms. Very characteristic references of palpitations of the heart, on flushings, especially during climacteric, flushing from the face, stomach, various parts of the body, followed by sweating, often hot and profuse, sensitive, plethoric women, and abruptly limited parts below are icy cold. Please note she mentioned from the waist downwards, flushes of heat. So as I mentioned, the vasomotor symptoms responded well to amyl nitrosum 30. Post-administration, she would develop a menstrual bleed. What was this indicating? It gave relief to the patient in terms of her symptoms. It prevented any endometrial thickening, and it facilitated a smooth and uneventful transition through menopause. Menopause, as I've mentioned already, is a phase of massive fluctuation of hormones, and you can get a lot of other symptomatology in its wake. And hence, this transition had to be made comfortable for this particular patient. As one phase of the flushes was getting better, the weepiness developed, calling for another remedy. Again, going back to the same statement that I mentioned, the same woman can have different symptoms at different stages of menopause transition, which is why it has actually been renamed menopause transition. The newer terminologies have been menopause transition. It does not stop with just menopause or the climacteric phase. Moving on to my second case. If I am too fast, please stop me, friends, and I will slow down. This was a lady of depression and hot flushes post Pan-Hysterectomy. So she met me after she's finished her Pan-Hysterectomy. She was 46 years old, again met me in November 2017. Her complaints was weeping and depression. Didn't want to meet anyone. She had not told anyone about her hysterectomy, only her husband. Even with her husband, she didn't really share a great relationship. She would control her tears in front of her husband. She kept thinking, was hysterectomy really needed? Why were the ovaries removed? Was there something more to worry? This kept as a loop in her mind. She had a lot of hot flushes with profuse perspiration and burning and waves of heat rising up. Her medical history was interesting. She was a case of deep vein thrombosis and had fibroids and had a lot of menorrhagia because of the blood thinners due to the deep vein thrombosis. Hence, she was advised hysterectomy. Now, during the surgery, the ovaries had adhesions and thus a pan-hysterectomy was done in October 2017. She was treated with the following for her emotional state: Natromur 1M, based on her tendency of being a closed person. Natromur 1M was given in infrequent doses, monthly once, or initially fortnightly once and then monthly once. Pulsatilla 0/3 as double dilution was given to her twice a day for her weepiness and because she had the history of deep vein thrombosis. Overall, for her emotional strain. And truly, I thought she's going to be fine. But she needed more assistance for her hot flushes. She needed the help of LACHESIS 1M and Whiskum Album 30 for the hot flushes. So this lady really responded within a month for her emotional symptoms, but her hot flushes took 5 months to settle. Like I said, when the mind was settling down, I never expected her case to move ahead itself. She did not respond to the usual medicines of hot flushes like Amyl, Nitrosum, Sepia, Javarandi, but finally settled with Whiskum Album 30. Why? Because I had missed this description, though I had mentioned it right in the beginning. It did not strike the description of a wave of burning like fire rising up from legs. Friends, most often a person will say that the hot flushes are on the face, on the neck, on the face, it drips. But here we found the previous case as well as this case where it was waist below. And this lady had the reverse order, like burning of fire rising from the legs upwards. And this was there clear cut in Boric's Materia Medica, climacteric complaints. A glow rises from the feet to the head, and it seems to be on fire. Why did I even move to a Whiskum album? I must say that this is traced back to a discussion with late Dr. R.P. Patel, where he described for some other case of his, an epilepsy case, where he said the aura was a glow from the feet rising up. And he mentioned to us that you're not going to get it clear cut. You have to use lateral thinking and see the concomitant in even the other portions of the boric. It's not going to come directly to you. And that conversation made me think about Whiskum album. Incidentally, Whiskum album, I use it a lot, though it's not connected to menopause, but I use it a lot on sciaticas. My third case of insomnia. This insomnia is a nasty situation through menopause transition. All sorts of patterns can come up. This was a 48-year-old lady, and she complained of insomnia since 1.5 years, just unable to fall asleep, lots of old thoughts, and hot flushes at times. She had a lot of menorrhagia, but was decided to do hysterectomy. She had irregularity of menses since 2 years. She used to get a lot of painful boils all over her body. Her mind, she was very anxious on her own health and family's health. And she was of late getting very hurried. She wanted everything completed immediately. And she would say that even as she is explaining it to someone, she would do it herself, because the way she described it was, if I'm telling my house help to do something, I would simultaneously do it, because I just don't think that they can comprehend what I'm saying. She was very loquacious, and every now and then in the consult, she would drift off in conversation and needed to be guided back. She had a family history where her mother underwent a hysterectomy, so she was definitely decided that she will do a hysterectomy for the menorrhagia, and she literally told me, you treat me for this insomnia. I am not able to sleep. Insomnia comes with many patterns. One is unable to fall asleep. Some have fragmented sleep. They keep waking up. Some will wake up at 3 o'clock. Some will wake up at 5 o'clock. Some will wake up at 1 o'clock. So you have a wide array for insomnia itself if we want to work on that. Nothing much on her physical generals per se. This was a long case again, but she was followed up for 2 years. LACHESIS 1M was given to her fortnightly once. And with Sabina saying that whenever there is menorrhagia, please take it 4 times a day. I did not have or tell her that it will control it, because her mind was already set on hysterectomy. This patient was on the same prescription from November 2015 to December 2017. In November 2015, she had a bulky uterus with a fibroid where the endometrial thickness was 10 mm. Like I said, a premenopausal woman is ideally to be less than 5 mm and postmenopause less than 4 mm. So in 2016, when we did her ultrasound, her endometrial thickness had come down to 6.6 mm. The bulky uterus and the fibroid remained the same though. She was, because of her menorrhagia, she was on lots of iron supplements. She was anemic. In March 2016 onwards, the patient stabilized in both menstrual irregularity as well as the sleep pattern. She met me November 2015. By March, she started stabilizing. In June 2016, we stopped the iron supplements that she has been taking from November 2015 because her hemoglobin had reached 13.9. By July 2016, she was sleeping soundly, sometimes excess, and if in deep sleep, she would take time to wake up, as she would say the eyelids were heavy. Her final menstrual cycle was on October 2016. So the patient was basically maintained on LACHESIS till 1 year of final menstrual cycle, that is October 2016. So again, most often this is what we do. We continue the medication for a year, 12 months, till we know that the person has truly transited safely through the 12 months of amenorrhea, which defines menopause. Menopause is a retrograde diagnosis. Most women will come to the clinic with 3 months of amenorrhea and say, I have menopause. Anywhere between 45-year-old to even nowadays, I'm finding even 43, 44-year-old women can come and say, Doctor, I've got my menopause. But unless it is 12 months, it is not menopause. Like I said, there can be prolactinemia, there can be PCOS, there can be so many things causing it. So till 12 months of the final menstrual cycle is completed, ideally, the person should be under treatment. Her general condition improved, her endometrial thickness improved. Her LACHESIS was selected. It was straightforward, the mental concomitant of loquacity and this hurried nature in her. The bulky uterus and fibroid did not reduce. However, post-menopause, it will anyways come down. LACHESIS was given it to treat her insomnia, and simultaneously her menorrhagia settled. And she transited through a normal menopause. She never landed up getting a hysterectomy done. So yes, It was unknowingly the buy one, get one free principle. LACHESIS, of course, has many, many references all over the Materia Medica as well as all over the repertory. But these were interesting references that I have put up here from the Encyclopedia of Materia Medica. The heavy morning sleep, gets up unwillingly, is a curative action. And Boric, of course, has loquacity, derangement of time sense, sleepiness, yet cannot sleep. As I said, the repertory is full of LACHESIS for climacteric period. One of the top, anything in the climacteric period, you will get LACHESIS. And LACHESIS has been a very strong remedy. I will talk about it a little bit, few slides ahead. And this will be my last case to describe here. Again, a very long case, so I've given prime salient features for this case. She came to me, a 45-year-old lady, in 2013 with anxiety, headaches, and hypertension. This particular case is a long case, but it will showcase how different stages of menopause, you literally have to handhold the person. As I said, the word menopause transition itself has a lot of weightage, and this case will highlight how we literally handhold and transit this person through from one phase to the next. Her chief complaints were, since 1.5 years, lots of anxiety, depression, fear of unknown, and a lot of negative thoughts. Her history was that her 12-year-old daughter had convulsions 1.5 years ago. Her sleep was very poor since then because she kept waking up to check on the child. This lady has 3 children. This child has a twin, and there's an older sibling also. So the patient had palpitations with anxiety, frequently headaches, were frontal and temporal, and she was recently diagnosed as hypertensive, and she was already on metoprolol, Met-XL 50 milligrams once a day when she met me, and she was stable with it. Her menstrual cycles were irregular since 1 year. So her family history was that her mother had breast cancer. The nature of the patient was she was very close. She won't share emotions unless she was prodded. Very social, and she would desire company. She was very sentimental. She will cry in movies, but when it came to close emotions, she will bottle up. She was always hurried, anticipating the worst when it comes to health. And she was always worried about health of herself, her family, even before the daughter's incident. Her husband is a healthcare professional himself. When she first met me in July 2013, her LH and FSH were already reaching the menopausal phase. She was given many different remedies through different stages, like Argentum nitricum 1M, Crataegus 30, Crataegus 200, Ignatia 200, Oromet 200. Intercurrents used were LACHESIS, Staphysagra, Glanoin. So this is a highlight of different phases where I had used different medicines for what indications. Argentum nitricum was predominantly used whenever she came in with anxiety, palpitations, and diarrhea. Crataegus was given to control the BP whenever they were fluctuating. Ignatia was given when there was anxiety and depressive phases. Aurum met when there was depression and BP fluctuations. LACHESIS was when the menstrual cycles became very erratic. They eventually stopped in 2016. Anxiety and BP were fluctuating quite a bit at this point. Staphysagra, there was an incident of a lot of emotional suppression. And Glanoin, she developed sun headaches when which got worse with sun exposure in between 2017 and 2018. Again, friends, this might look like many medicines at many stages. As I said, the same woman can go through multiple symptoms in different states. Each month is a different story. And this is what we noticed. So some notes over here. Now, 2016 was a difficult year for her. From January to August 2016. Before that, 2013, when she came, she was going fine. She was on few medicines. The main fluctuations started coming from this phase. From January 2016 to August, her BP would go to 140/100 and then come down to 120/90. This was a time her twin children were giving their 10th standard board exams. There was also a financial strain at this point because some money got stuck in an apartment that didn't get completed. Her menstrual cycles had become erratic, scanty, and eventually stopped by end of 2016. Soon after 2017 and 18, she developed a lot of headaches. And from 2018 to 2019, she shifted to her new apartment, the same apartment that where the money got stuck. She shifted into it. She took 10 months to adjust to the new environment. She had a lot of pent-up emotions, a lot of preconceived emotions because she had a quarrel with her sister who she was very close with because the sister got burnt during the gas cylinder which burst during the housewarming ceremony of this whole apartment. So right from the time where the money was stuck to the time of shifting to this gas cylinder burst to the quarrel with the sister, so many things happened in this phase. I'm going to talk about how her metoprolol, the BP tablet, how the journey of this particular BP was. Her BP was 150/100 when it was diagnosed in 2013. It was stable at 130/90, and she was on Metexcel once a day. In May 2014, her Metexcel was reduced to 25 milligrams. She was on Metexcel 50 milligrams once a day. And May 2014, her Metexcel was reduced to 25 milligrams by her physician as the BP was stable at 130/80 or even 120/80. By February 2015, the Metexcel reduced to alternate days in consultation with the physician. Now, her GP was not particularly happy with this alternate day phenomenon, but the patient requested and made it alternate days. In March 2015, the patient reduced the Metexcel to weekly twice after consulting with me. Her BP remained stable at 120/80. She was emotionally stable. To which I said, okay, go ahead, weekly twice. Now, January 2016, the Metexcel was decreased to weekly once. This was the time where there was a lot of fluctuation. But her BP was, though she had reduced it to weekly once, her general physician said, listen, you might as well stop it because it is not going to do anything. But the patient was going through a lot of emotional variations, her children's board exams. So hence, at that time, she did not want to increase the Metexcel, but she did not want to get off it either. So we hung on with our homeopathic medicines at that point, looking after her emotional status, looking after the BP. And by 2018, the patient was confident to reduce Metexcel to once in 2 weeks, and then she stopped it in August 2018. This is something that I would like to, I know this is a long period of time, 2016 to 2018, to be on more or less like a placebo dosage, but the patient's mindset is very important to take care at this point. Her BP is stable, remains stable at 120/80 or 110/70 throughout this phase. Now, once there is a menopause, once the sex hormones are done with, there is a lot of change, especially in the BMI. And this leads to many different pathological formats, leading to hypertension in a woman. A lot of phenomenon takes place, and looking after the person in this transition phase helps us control different various pathological phenomena, different various mental health phenomena, and hence we are able to transit the woman through a safe menopause. This patient still visits me on and off. She's emotionally very stable, well adjusted to her new environment, and her BP remains within normal limits, no headaches. For this lady, I used the green climatic scale to evaluate and to understand what was happening. Frankly, some of the previous cases, I didn't know much about the scale, and I wasn't able to comprehend how to use it in an outpatient setting, how to aggregate so many follow-ups, and slowly I learned. So the first visit was a score of 18. Her symptoms reported were heart beating quickly, strongly, feeling very tense and nervous, difficulty in sleeping, anxiety, panic attacks, unhappy and being depressed, headaches, muscle and joint pains. When she came, this was her climactic score, 80. Slowly, it started coming down. She was stable at 3. 2015 was a great year. And then came 2016, 2016 with the board exams, with the money being stuck, with lots of emotional variations, and you can see how she fluctuated. So this kind of a graph really helped me understand formats later on. And then slowly again, she stabilized and maintained at a more or less stable phase till 2019. So from this study, what I mentioned, the 150 cases and the 5 different types, there were different observations that I made. There are most importantly 5 different types of observations. The first one was the age distribution. Most of these patients reached out for help between the ages of 40 to 45 and then 46 to 50. So 49% of these cases were coming in at around 40 to 45, and 45 to 50 was 28%. And then still between 51 to 55, around 15%, and 56 to 60. At 56 to 60, it is really moving from midlife onwards. So there are other conditions. The most common presentations were actually hot flushes, anxiety, and constipation. Honestly, I thought menorrhagia is going to be the main presentation. But when I did this study, I realized that hot flushes was the most important aspect that women were reaching out for. And then constipation and anxiety and palpitations, bloating, constipation. Many remedies covered this wide area of symptoms, but 4 remedies were pretty high. LACHESIS, as you can see, was the highest, then pulsatilla, calcarea carb, and amyl nitrosum. This was an eye-opener. The top 4 remedies covered different presentations to varied degrees. LACHESIS and pulsatilla covered maximum, except when it came to hot flushes, where pulsatilla didn't do much, but LACHESIS and amyl nitrosum came in quite a bit. From a remedy perspective, when we look at LACHESIS had an equal distribution, more or less predominantly for hot flushes, for menorrhagia, for insomnia. As I said, each of these symptoms become concomitants to the other, so certain combinations started developing. And I realized that certain remedies were working with these certain combinations. So when I saw lots of hot flushes, menorrhagia, insomnia taking place with an irritable person, with a loquacious person, LACHESIS just fell into place. LACHESIS, I would also like to say one important factor is when there is a lot of erraticity, LACHESIS is like herding the sheep together. It will eventually lead from everything being scattered around, it will literally lead to a linear movement towards the proper transition. Pulsatilla helped again with menorrhagia, with insomnia, and with constipation. Pulsatilla, I was more used to pulsatilla for amenorrhea. All our books talk of amenorrhea, but that's the point. It is the menopause transition, or wherein hormones are going to be erratic. So there is anovulatory cycles, amenorrhea for 2-3 months, and then the menorrhagia. So it was those kind of cases where pulsatilla worked better. Calcarea carb worked predominantly when it came to menorrhagia. Like I said, when there was so much of amenorrhea, and then there was that menorrhagia, the pulsatilla came in predominantly, and any menorrhagia with protracted menstrual cycles and just heavy gushing without much of an amenorrhea, those cases, calcarea carb helped predominantly. Amyl nitrosum helped with hot flushes and insomnia. In terms of diagnosis, there was a long list, 22 diagnoses from 150 cases, and some of which had to be, put into a diagnosis because sometimes it's just not a clear-cut diagnosis either. But most of the cases were either hypothyroid or fibroid. But what was interesting in all of this was predominantly these diagnoses were psoric in nature, and to a great extent psychotic, and very few into syphilitic. The remedy, this is something we all know. It was just highlighted when it came to hypothyroidism. I just took just the two top, the hypothyroid fibroids. LACHESIS covered 13 cases of hypothyroidism, calcarea carb, amyl nitrosum covered 5, pulsatilla covered 8. In terms of fibroids, LACHESIS covered 7, calcarea carb in 2, pulsatilla 1, amyl nitrosum 3. So the diagnosis per se was not of much value because the remedies anyways covered them. And this shows the wide therapeutic range of homeopathic medicines that we have over this whole menopause transition. So what did I understand? The results were determined for the 30 cases of each for the different 5 presentations. The symptoms, if they were improved, the symptoms were better. Improvement was judged by symptoms being better in frequency and intensity. And if the pathology was present, it still remained. Cure was when symptoms disappeared completely and pathology was also better. Same was when symptoms and pathology all remained status quo, and deterioration was when symptoms were aggravated. So these were, as I said, the top 5 presentations, that of menorrhagia, anxiety, palpitations, insomnia, hot flushes, and constipation. And what we saw was that 61% were on the improvement, 19% were cured, 19% had a status quo that is same, and 1% was deterioration. The main deterioration we saw was in insomnia. Insomnia is one of the toughest aspects to treat through menopause transition. Relationship of age and response. Whatever be the presentation, as I said, they predominantly reached out between 40 to 45. And the response rate also was best at that point. Thereafter, when 46 to 50 also, response rate was better. But this was the crux, that they reached at 40 to 45, and the capacity to treat them and get a successful result was also predominantly at that same age group, 40 to 45. So if we go through this similar chart, 58 remedies were actually present, and the top 4 remedies clearly were higher, covering most of the complaints and concomitants. The results table showed that there was 61% in improvement, 19% of cure, which gave us 80% positive response. age and response tables. The best results were between the age of 40 to 45. This was followed by 46 to 50. And this highlighted the fact that early intervention is very, very essential. The miasmatic understanding from the diagnosis chart that predominantly during menopause, we saw that it was SORA and psychosis that was present. And if you understand it from the remedy perspective, from the 4 main remedies, 3 were polycrists. So they covered all the 3 miasms, LACHESIS being more psychotic syphilitic, Calcarea carb being more, and pulsatilla being more soric and psychotic, but I would say LACHESIS being even soric because it really covered many cases. Smaller remedies. My eye opened to a lot of these small remedies with the case studies and with just going through different cases. From those 58 remedies we saw, remedies like biscamalbum coming up and mild nitrosum coming up, and they had a large role to play in the management of menopausal symptoms. So coming back to my concept for the thought process of concomitants, aphorism 103 and protocol. We are aware that there is a wide range of symptoms available at this point. Each symptom is a concomitant to the other. It is such a wide supply that you can easily get lost. This study showed that some medicines had a higher affinity to cover most symptoms and concomitants, and that's how the thought process of a protocol came into being. But I must say, a protocol has multiple steps. Step 1, step 2. If this doesn't work, that works. I never went into that because the individuality of homeopathy is very, very important, and we cannot compromise on individuality for homeopathy. You can only think of initial guidance. Another interesting observation was this was a trio, the anxiety, hot flushes, and insomnia. They worked together, and if a person had a predisposition to anxiety, everything would be heightened. Like the last case of the hypertension and anxiety and the headaches. She had a predisposition to anxiety, and so many people have a predisposition. To them, this trio tends to get very heightened. And this trio is a precursor to a lot of non-communicable diseases. So once again, friends, aphorism 103 understands SORA from many single patients. Antisorics are remedies of several patients studied. And so also menopause transition is a wide variety of symptoms. For the same individual or different individuals, it is a wide range, and the requirement of widely applicable remedies is important and equivalent to a quick intervention. I did not put up aphorism 103 on the slides, but I would like to read it. I didn't put it up because it is a long aphorism and too much of text for a slide, but I would like to read it in this context again. And recently we had Dr. Ravi Doctor who spoke for IHMA, and he mentioned in terms of COVID, of course, aphorism 101 and 102, and he also mentioned aphorism 103 in context to COVID. Today I will read out the aphorism 103, which states, if we really think of it, in the same manner as has been taught relative to the epidemic diseases which are generally of an acute character, the miasmatic chronic maladies, which, as I have shown, always remain the same in their essential nature, especially SORA, must be investigated as to the whole sphere of their symptoms. Again, understand it is the whole understanding of SORA in a much more minute manner that has ever been done before. For in them, also, one patient only exhibits a portion of their symptoms. A second, a third, and so on, present some other symptoms which are, but a portion of the totality of symptoms which constitute the entire context of this malady. So each individual is going to show some portion of a psoriatic complaint. Each menopausal woman will show some portion of it. So that the whole array of symptoms belonging to such a miasmatic chronic disease, and especially to psoriasis, can only be ascertained from the observation of very many single patients affected with such a chronic disease, and without a complete survey and collective picture of these symptoms and the medicines capable of curing the whole malady homeopathically cannot be discovered. And these medicines are at the same time the true remedies of several patients suffering from such chronic affections. So once again, friend, that's what I'm trying to say. This thought process was that Sora was understood from many individuals. Anti-Sorics came from many individuals. Similarly, many individual women, through their varied presentations, showed what menopause transition can mean, and a wide variety of symptoms. And even the same woman can go through any of those. So they become concomitant because not necessarily all are connected to estrogen and progesterone. And that's how they become valuable concomitants for us. So friends, menopause transition is different for every woman. It is important to transit safely physically, emotionally, mentally. Early intervention will give quick result and cause the stability of the patient. That is the most important. That once the patient is stable, we know that more or less they will be fine throughout. Some remedies like LACHESIS, calcarea, carb, pulsatilla, amyl, nitrosum had a higher capacity of addressing multiple symptoms and concomitants together. And that's why they were the basis or the basic form of a protocol. As I said again, and I will always highlight this, that individuality of homeopathic prescription can never be overseen. This is only a good starting point to address menopause transition, because sometimes there is a wide array of symptoms and it can confuse the physician. The individuality of the prescription I highlighted again, where this starting point and this protocol was not very helpful when it came to the viscoamalgam case. So individuality cannot be bypassed. Just sharing some of my journey with the Indian Menopause Society. My first time I introduced to them homeopathy for menopause transition was in 2018, and it was recognized, and that was a huge step for me. Thereafter, I was invited by them in Chennai for a panel discussion on metabolic syndrome in 2019. 2020 saw a paper again getting recognized, evaluating the role of homeopathy for mental health through menopause transition. This patient who I spoke about, who went through the BP, the headaches, the hypertension, the anxiety, the palpitations, I had showcased her case over there. And again, I'm very happy to say that they recognized it. And again, with the era of webinars, so I was invited to be a panelist for the discussion, Independent at 80. The Menopause Society has a beautiful slogan, and I think this is a slogan that we have all heard. It's not exclusive to them. Fit at 40, strong at 60, and independent at 80. This has been a very passionate subject of mine, and I'm very happy to say and humbled that I had platforms which gave me the opportunity to speak. And one of the first platforms was the LMHI in Italy, thereafter the IHML at Erode, and the Karnataka Qualified Homeopathic Doctors Association on the webinar. I cannot end by not thanking IHMA for this fantastic opportunity. As I said, it is my favorite subject. I always remember Dr. Aarti Patel from Gujarat, whether it is the Whisk amalgam, whether it is aphorism 103, to connect cases, to connect a prescription to the organon was taught by him, and I sorely miss his guidance here. Dr. Matani from Mumbai, Dr. Jayesh Sanghvi, my mentor, from whom I started my baby steps way back in 1995 actually. Dr. Alim, Dr. Venkatraman, Dr. Jagata, who have always guided me. Dr. Jayashree Gajraj, Dr. Vijayalakshmi Shishadri, my seniors and friends from the Menopause Society who have always guided me in gynecology. My heartfelt thanks to my team in Chennai, my past, my present team, Dr. Nila, Dr. Smriti, Dr. Preeti, Dr. Nivedita, Dr. Nritya, Suprabha, all of them who have helped me compile and analyze data, who question the data, who question the prescription, which makes me think. My patients who with confidence subject themselves to homeopathic treatment under me. And my family, I will always say this, that at every stage of my medical career, they have patiently tolerated hours of absence, especially Sundays. And of course, they do ask me, how is it that every Sunday you disappear? And well, what to do? Sundays is when it all happens. These are some of the references for this particular presentation. And thank you, IHMA. Thank you all for giving me this opportunity. And I'm happy to take up any questions. And usually, I've seen everyone taking the whole 2 hours. I have been one to do it in 1 hour so that I can take up questions. Thank you.
Thank you very much. Participants, if you have any queries, please put in chat box so that I could ask Dr. Koshali. Dr. Samina Kapasi has raised her hand.
Yeah. Hello. Good evening, Dr. Kushali.
Good evening.
Yeah. My question is, in the last case, you've given a lot of remedies, like, for example, urgentum nitricum for palpitation, then for BP you gave Cratagus. So at what stage, like when to give, which remedy, how you decide, or you give it together? Because palpitation, hypertension were the presentation. So which, that was too fast. So can you tell in detail, when and how you went about, changing remedies?
Sure. So how I do this is usually I would give, so as you notice, argentum nitricum might be 1 m, and I give medicine sometimes together. So argentum nitricum 1 m could be followed by Cratagus 30 twice a day. Argentum nitricum 1 m will be a single dose, or it will be once a week, or once in 15 days, or even once a month, based on the presentation. And Cratagus 30 would be twice a day, or it would be usually twice a day. I rarely go 3 times a day unless it's a very acute, then I give it in water dosage. But not in this case. I've never needed to use water dosage for this particular case. But each of those, like Glonoin came up. So Glonoin came up and she developed post-menopausal migraines, and sunshine was triggering it up. Her BP was already fluctuating, and there was this time that Glonoin was given to her weekly once, Glonoin 200 weekly once. That is my usual way of giving Glonoin. Argentum nitricum also usually is as I said, weekly once or fortnightly once. Cratagus 30, the 30 potencies, 200 potencies will be in twice a day.
Thank you. Another question from Dr. Fijala. Do we have any protocol for fibroid?
Yeah. Fibroids, yes. A protocol, no. Fibroids, one of my favorite prescription is Calcarea fluid 10 m once a month. And then if there's a lot of bleeding because of the fibroid, it is goes to Thalapsy, Bursa pastoris. And I have found results with this calcarea fluid 10m. Sometimes I have gone to calcarea fluid 30, multiple fibroids. I would go by, I think it was Clark's reference, Kali IO 30. He's mentioned it as the uterus is full of fibroids. So there it would be Kali IO 30. So many fibroids, then it would be a 30 potency more frequently. One large fibroid or two large fibroids would be 10m monthly once. There would be other, and then followed by thalapsy versa pastoris. If they are bleeding, if they're not bleeding, then whatever, SL or whatever, if there is something else that needs to be addressed, then.
Question from Dr. Nandini: how to differentiate perimenopause and menopause symptoms?
Okay, that's a very interesting question. So, so let's put it this way: perimenopause is when. So the definition goes that perimenopause technically starts anytime after 40. Average Indian women 42, 43, where various symptoms like hot flushes or skin changes, hair, complexion changes, insomnia start. As I said, menopause is not a disease, it is a phase. So perimenopause is a phase, but premenopause is what is defined when the actual menstrual irregularity starts. So nature gives us that good 10 years of an acclimatization time when you start noticing varied symptoms coming up in a perimenopausal woman, who's classically predominantly the age defines it above the age of 40, because at this stage still she will not be, her FSH, LH will not be reaching higher levels for us to call it really menopause. So she still is at the perimenopausal, menstrual cycles are normal. So it is only perimenopause, and perimenopause can last 2 to 8 years before premenopause sets in.
Question from Dr. Jitesh: any relation between frozen shoulder and menopause?
Wow, I'm suffering from frozen shoulder now. So I would love to say yes, because frozen shoulder does tend to come in. Most of the joint and muscular problems do tend to come in after the age of 45, 46. So there is no direct correlation, like we said, that it is not connected to estrogen, progesterone directly, but sarcopenia is connected. So the muscle loss is connected. So of course, by the time you reach sarcopenia, you have to have really atrophy of the muscle, which usually we don't really see so much unless because people are pretty aware and they are working or doing some exercising or doing something at least. But yes, the joints, let me give you the understanding that I have for frozen shoulder right now, because I'm going through it myself and I'm 49. So the muscles of the upper back do tend to get weakened. And what we notice is the slouch starts developing, which is what tends to inflame the tendon of at the shoulder. And that's when you don't realize it in the day-to-day activity, but that's when you realize that the upper back muscles, the scapular muscles, are the ones that really need the exercise. Physiotherapy of mobility exercise, wall crawl, help a range, but they do not really help much with with really correcting the whole torso. And it is the upper back muscles, because they do tend to get the latissimus and the scapular muscles do tend to get weak initially because of the lifestyle, because of whether it is waning hormones. Exactly like we said, there were a lot of some such symptoms come under the range of menopause, but not necessarily directly correlating to estrogen and progesterone. So they do come under the aging process. But yes, and in terms of medication, I have started to see results. I mean, I've definitely seen results with Ferromet to a great extent, Ferromet, Ferromure. And of late, I have been starting to use thiocinamide. But one thing I would definitely say that withdrawal from texting, typing, reading on a gadget, it has to be implemented because it is very detrimental for the upper torso muscles, and that unfortunately does tend to draw back and it prevents our homeopathic medicines working well. I don't know if I have answered your question well, but yeah, that's my understanding of frozen shoulder and perimenopause.
Thank you. And do we have any specific remedies for post-hysterectomy hypertension, where this patient was had normal BP before hysterectomy? So after hysterectomy, hypertension has developed. Do we have any remedies from Dr. Shankari?
So if you look at the repertory, LACHESIS, CRATIGIS are the top. They're on the 3-mark, 5-mark range. Then you have Amyl, Nitrosum if they're going through hot flushes simultaneously. And and Glonoin if they've got headaches. So the presentation of the hypertension also plays a very important role. But at such a phase, I will give more weightage to the constitutional remedy for this person. And repertory-wise, LACHESIS and CRATIGIS come up the highest. Next is, as I said, Amyl, Glonoin. Aurum met comes in. Depends upon, again, if there is a mood fluctuation, any osteoarthritis coming in post-hysterectomy. So any joint arthritis being present. So then, again, Aurum met comes in.
Thank you. Another question from Dr. Kinjal Sharma. Your experience in prolapse uterus cases, and there are 3 questions actually. Experience in prolapse uterus case, and any idea about diet tips for menopausal women. And last question is fibroid with pregnancy, how should one go about?
Prolapse first. I have not seen gross prolapses because the gross prolapses don't really come, but I have seen a lot of urge, stress incontinence, mild prolapses, and one of my favorite remedies is causticum there. So causticum 30 twice a day with constitutional medicine. And sepia comes in again if there is a lot of urinary issues at that point. If there is a lot of vulvovaginal irritation because of the prolapse, creosote is one of my favorite remedies. And creosote is another very, very important remedy that I use because of different vulvovaginal problems, because there is prolapse, there is atrophy, there is estrogen depletion, and at this stage, there is also a lot of dryness and causes a lot of vulvovaginal itching, can cause infection at that point, and it can cause little inflammation, abrasion because of coition at that point when there is a dryness of the membrane. And creosote I have found very, very useful here. And in terms of the prolapse per se, causticum has helped me the best. What was the second one was?
Diet for menopause.
Diet for menopause. A very simple thing. Yes, lots of diet. Not lots of diet. Sorry, no one will come to us then. And they don't necessarily need to come to us because there's a wide array of dietitians to go through. So actually, our simplifying it is our strength. So I'll give you a very simple formula that I follow. And so height in centimeters minus 100. So let's say average Indian women 5'2", 5'3". So usually they are 157 centimeters, 160 centimeters. So minus the 100 is the weight in kgs. So 57, 60 is approximately that person's range. This range is post-menopause. So ideally, we want this person to be 57, 60, whatever, the height in centimeters minus 100 after menopause, because when there is a transition of the hormones, there is going to be weight gain. The reason for this is the estrogen is going to be depleted now from the ovaries. The source is depleted. So the other potential source for estrogen is the fat cell, to which there will be abdominal fat and thigh fat developing, gluteal thigh fat developing. And it is important. Nature has allowed it to develop because it is required for other functions. Estrogen is required for sleep cycles. Estrogen is required for cognition, for skin collagen. So it is going to be required. So this is the ancillary source, provided the person exercises well, so that it mobilizes it from the fat cell to the necessary cells. If they do not exercise it, this gynoid fat, that is the abdominal fat, the thigh fat, the gluteal fat, will only increase in whatever proportion it desires and leading to problems. So if we keep the weight within that range, why is that range? Because 18 to 25 is normal BMI, is healthy BMI. Height in centimeters minus 100 is the weight in kgs. So 157 centimeters minus 100 is 57 kgs for that particular woman, which is equivalent to 24 point something BMI. And that's the reason why it is important to see this figure. And we tell women, now the advantage of homeopath has is because you're seeing these women in different stages of her life. We see women, whether they come for a cold, they can come for whatever. So many things. They're coming for their children. They're coming for so many things. So we have access to them, which is one very important thing that was highlighted when I was invited to be a panelist on the metabolic syndrome by the Chennai Menopause Society. What came up was that the woman finishes the delivery with a gynecologist, and that's it. The story ends there. So by the time she has reached out for help, she has already developed hypertension, already developed a gynae problem for which she's going, and she has already developed a thyroid or some endocrine problem for which she's reaching out to the endocrinologist. She has not had the opportunity of guidance somewhere in the middle, unless she's taken the second child. So the pediatrician should be aware of this, or in that particular seminar that we had, I think some of our members did attend that. This was a very important factor that came to highlight, which is our strength of a homeopath, because this is something that we are going to see her. And if you tell her right from the age of 35, 40, that listen, nature is going to give you 10 years for menopause. So start working on it, and this is your target. So if your height is 100, at the age of 40, you're not going to grow in height, that's for sure. So if at all anything, you're going to lose height because of osteoporosis. God forbid that happens, but you might lose height. So 157 centimeters has to be 57 kgs after 12 months of amenorrhea, after menopause. So then their metabolic status is kept well, their BMI is healthy, the joint problems are less. So this is the directive, that the first thing that I say. Second thing I do tell them is a lot of vegetables need to come into play. And I also tell them that if you look at the nutrition pyramid, it talks of 5 cups of vegetables per day. And if you look at a healthy plate, it speaks of 50%. Half the plate is vegetables, quarter plate is carbohydrate, quarter plate is protein. Now, our Indian diet does not have that much of vegetables. People will come and say, but I'm vegetarian. But what do you eat in vegetarian food? You will eat paneer and you will eat potatoes. So where did the vegetables go? So that's something I do take the time to help them. When it comes to insomnia, as I said, insomnia is very hard. one of the important factors in insomnia is lack of sunshine. Today, everyone is happy to pop vitamin D supplements, but they don't want to go out into sunshine. And this lockdown has made things even worse. Now, sunshine gives us serotonin, that everyone knows that sunshine gives serotonin, and the same serotonin is getting converted to melatonin. So if you don't have sunshine, how are you going to get melatonin? So melatonin is required for sleep. So by popping in a vitamin D supplement, you're not going to get, that is very, very literally looking through a horse's eye for the whole general health. So, and so that's another aspect that I do highlight to them. And yeah, a decent lifestyle of sleeping early, good sleep hygiene. And yeah, so those are the dietary as well as the sunshine aspect that I do highlight in terms of lifestyle. And there was one more thing about it: fibroid during pregnancy.
Yes. Fibroid and pregnancy.
Pregnancy, a tough one, very tough one. But yes, again, my calcarea fluid is one of the things that I do tend to go into. But in pregnancy, I monitor the person every 2 weeks. So whatever be the other symptomatology is addressed simultaneously. And the rate of growth, if the rate of growth of the fibroid is very fast, then yes, intercurrents like Thuja is anyways given at that point. So, but I resort mainly to Thuja, calcarea flow, and whatever that person is going through. So if during pregnancy, if they're going through insomnia, then that needs to be addressed, because again, that will hamper the fibroid. So, but it is a very tough journey.
Okay. Another question from Dr. Soumya. Can you share about the curative part of LACHESIS, which you have mentioned in the references Allen's encyclopedia?
So, LACHESIS, the Allen encyclopedia was a very interesting note, because in that particular patient, her insomnia, when she started getting better, she complained that I'm so drowsy now that I can't wake up in the morning. My eyelids are heavy and it's an effort to open them. And at that point, when I was reading, I had read this a little earlier than that, so I recognized it. Because I had read it, I recognized this to be, it is mentioned clearly in Allen's encyclopedia that it is a curative action. So at which point, because I had read that, I was confident about that symptom, and I did not change my remedy. Otherwise, seeing that heavy eye, I could have changed it and said, should I be changing to gelsemium here or not? But because of this sentence that I read, I hung on and maintained the same drug. But LACHESIS, on the broad sense, if you ask me about the curative, when there's confusion, when there's loquacity, there is hypersensitivity, there are erratic menstrual cycles, there is suddenly a bleeding, suddenly, there's a BP rising, there is suddenly protracted menses. LACHESIS 1M is something that I just give, followed by whatever, because I do find it really herding the person. I'm saying this herding, like herding sheep from all over towards a linear prospect of coming towards some pattern which we can take up and follow on to transit through menopause.
Thank you, ma'am. Ma'am, there's one case doubt.
Yeah.
Dr. Adarshina has asked, a patient of 56 years who attained her menopause 5 years back. She was diagnosed with fibroids even before menopause, but since her menorrhagia stopped and menses also stopped, the doctors advised not to worry about the fibroid. But each year, when she goes for investigation, the fibroid is increased in size. And she also has a family history of uterine and rectal cancer. What to do in such case?
Biopsy is needed. This can be a leiomyosarcoma. So because it's not meant to, what is really feeding this fibroid? So if it is growing, because yes, after menopause, the fibroid is supposed to come down. So definitely, at least an endometrial biopsy is required, and it could very well be a cancerous prospect. While I would say that this biopsy is needed, offhand drugs of choice would be carcinosin 30-100-1M, something that I have learned from my mentor, Dr. Jayesh, who I've seen him using this, and he's got it from his mentor, Dr. R.P. Patel, and basically traced back to Phobistus carcinosin, where carcinosin 30-100-1M is the way of is the format, because there's a family history of carcinoma and there's a suspicion over here. But I will I will 100% get a biopsy. I will insist on a biopsy for this particular patient.
Thank you. Dr. Nitya ma'am has asked, what helps the vaginal dryness the most in homeopathically?
As I said, creosote. Creosote is something that I've always resorted to, and I've always found it very useful. Belladonna, but I'm not, belladonna is there. I've used it occasionally. If that's Dr. Nritya Dave who has asked this, then belladonna is actually her prescription. Is it her?
Yes, ma'am.
Yeah, then that's her prescription actually, belladonna. She's an ace at belladonna. But my prescription is usually creosote. So creosote is what I usually rely on for atrophic, for the dryness of vagina.
Thank you, ma'am. I guess this would be the last question. One of the curious daughter has asked, any tough or peculiar case regarding menopause in your clinical experience?
Yeah, there have been tough cases which I have. I've had one, but I could not help her much. It was a very tough case because so she had, this was quite many years ago, she had a fibroid, she was bleeding, but she also had a AV septum. So she was not very surgery conducive, but eventually her bleeding never stopped, and then finally she had to go through a hysterectomy, and it was a tough hysterectomy, but she went through it at least. So that was one of the worst and most difficult cases I've had. And apart from that, sometimes the menorrhagia, if it is not settling, then the patient only gets fed up and gets the hysterectomy done. But it is more of being fed up and not giving it time, because within 2 to 3 months they go away sometimes. And but those who stay on definitely transit. They definitely transit. What is the difficulty that I find is no follow-up. Like I said, the moment they are better, this happens in menorrhagia, they don't understand the concept of you can still go into amenorrhea and then a menorrhagia. And that's what brings us that it is important that 12 months of follow-up after the final menstrual cycle is needed, but they're not necessarily follow that up. The second aspect is that when they just take it easy once the menorrhagia comes down, and then suddenly after 8 months you can have another bout of menorrhagia, then they get fed up again. Should we do an hysterectomy? So cajoling the patients is the most difficult thing that I find. Keeping them on, they wonder, now I've not got my menstrual cycle, so why should I continue treatment? But what they don't realize is that the definition of menopause itself is 12 months. And 12 months, you can have so many different aspects. For example, hypertension can come up. You can get insomnia, you can get depression, you can get osteoporosis. But if they've come to you for menorrhagia, they don't really stick on, and then they can get a bad bleed. Another difficult case, 2 cases which I would say they were not difficult, but they were frightening. They were frightening, and luckily, thank God, they're all fine. Both of them are fine. And that is where, the promptness of this endometrial thickness is there is, so one lady, she tells me, she calls me up. She's been my patient for whatever colds, coughs, predominantly sinus. And then she just tells me that I am going day after tomorrow to USA, and I'm going to be away for 3 months. But I have got some sort of a bleeding. I don't know whether it's from the vagina, from the urine. I used a tissue and I saw a spot. She is menopause. She was at that time, I think 58 or 59 something. And so I said, no, you can't go. You're first going to the ultrasound center. She didn't go the next day. She went and got the ultrasound and boarded her flight. And the sonologist is calling me and saying, doctor, she's got an endometrial thickness. And I don't know what to do with this now because she's gone. And I finally called up her daughter in the US and I said, see, this is what has happened. I don't know how much to push it. I don't know whether she has medical insurance or she can go and see a gynecologist over there. And so she went, and when the daughter said, okay, I'll speak to her and all of that, then they called me after she reached USA and she said, but there's no spotting now. So I said, okay, but this is not healthy. So 2 months, instead of 3 months, she came back in 2 months, and 2 months was tension because she kept getting spotting middle. She came back and I said, redo your ultrasound. It was thick. The endometrium was more than 10. I said, you definitely need a biopsy, and it was endometrial cancer. And she finally went through a hysterectomy, and she went through chemo, etc. There's another case who very obese, 122 kgs is this lady. And she used to come for various, predominantly an IBS symptom, but a lot of psychological symptoms. And again, menopause. And then one day she said, hey, I don't know what this is. And I said, no, you need to get it checked. She got it checked. Endometrium was thick. In 1 week, all this happened. Fortunately, she was in Chennai and she listened to me. And I said, please meet the gynecologist immediately. Endometrial biopsy was done. It was cancerous. Hysterectomy done. She was safe. So, so this identification is an important factor. Not all endometrial thicknesses. Having said that, these two were frightening cases, but having said this, there have been many cases where I get after 1.5 years, that is after 18 months or even 20 months, there will be a bleed. But the protocol is get the endometrial thickness done, see if it needs a biopsy, and very often it is actually an atrophic bleed, the last of the atrophic bleeds. So not all will need a biopsy, but it is important to do the ultrasound and see how their endometrium is. So that is something that I would say is the vigilance of menopause.
Okay. Last few questions. Dr. Raghavi has asked experience with the patient with formication during menopause.
Formication means you mean the tingling, you mean
tingling sensation on the skin.
numbness. It depends. Is she diabetic? Is she pre-diabetic? Then that varies, but otherwise, whatever the constitutional medicine, and I would give hypericum. If it is more towards the soles, then I would give Berberis vulgaris. If it is more towards the thigh, if it is associated with insomnia, I would give Zincomet. So the case will speak of it. Again, I would search for concomitants.
In case of healthy women, menopause in healthy women.
All women are healthy only. Menopause is going to happen to every woman. The problem is when they, in a healthy woman, why will you do anything? I mean, like a pregnancy, all pregnancy is good only. So you just help them. You don't necessarily need to do anything much. You just, if they're coming for whatever reasons, then you maintain them on constitutional medicines. That's about it. See to it that the immune system is taken care of. That's about it.
Yes, this would be the last question, ma'am. Your remedies for insomnia of menopausal women.
LACHESIS, LACHESIS. And then arsenicum album, the 1 a.m. waking up, 3 a.m. Is Thuja, Kalika. Then again, in insomnia, the racing of thoughts. So I asked them, what happens? Why are you waking up? What is the thought process? Thought process, if it is some old thought process. Why did my family do this to me? Lots of these old things can come up. What's the reason for menopause? For all these old problems to come up, we don't know. The theories are that maybe because of the estrogen receptors coming down a bit, in the brain, that you do get old memories. But these old thoughts, why did family treat me like this, etc. So there comes Natromure, there comes Staphylococcus aureus 1M, 1 dose. If this lady has a thyroid dysfunction somewhere in the middle, I would go with Natromure. Then Ignatia comes in. Then so that is one. Then there are some who are just wide awake, and I just lose sleep, finish, and I'm tossing and turning. Then comes then I ask them, what happens if you don't get sleep? Yes, I get a headache. Then cocculus comes in, racing of thoughts, cocculus. Then Califos, to Califos 30, 200, Califos 6x. So varied combinations or varied prescriptions come in. Zinc met, again, if there's a restless leg. Restless leg, the patient will not come and tell you I have restless leg. They're going to be like how Dr. Patel described it. They're going to be two different incidents in the patient's mind. It's our job to connect the two. So then zincum met comes in. How restless are they? Sometimes I ask them, you'll end up kicking. You want something on your leg. So causticum and zincum met come in those cases. Then this 5 a.m., they will wake up. Those are the natrum sulphs, because of those are all the Boger timings, go by Bogers. So the 1 a.m. is arsenicum album, then the 3 a.m. is Thuja Kalika, then the 5 a.m. is natrum sulph. Then comes whatever concomitants are coming in with it. What are the thought process of which is coming in it? Is it planning for tomorrow? I have to wash the dishes, tomorrow's menu. Again, cocculus will come inside. So it is a combination of these different thought process, different concomitants and symptomatology coming in.
How to end this session, but another one question popped up. I'm really sorry. Your experience with Simicifuga or Ectera simosa?
No, more in younger women. I use it more for acne, mainly for acne. I use it, and sometimes Simicifuga, I've not landed up using it as much, though they say that there's a cloud of depression on the head. I've not used Simicifuga. I've not had results with Simicifuga as much as I directly get from Ignatia. So I've not used it so much for depression, though it is there. Simicifuga is one medicine that I like for tendoachilles pain. So if, again, just like someone asked for frozen shoulder, this is also another thing that crops up. So that's another area. Or pain in the belly of the muscle. So those calf muscle pains, tendoachilles pains, that's where, but I did not use Simicifuga that much.
Thank you very much, ma'am. I hope the queries have, that's the end of the queries. Actually, it would become a great guilt in my life if I don't thank the speaker. So let me, since I started with some different language codes, I'll end this session by thanking in my mother tongue, in the famous Tirukural, which is known as Ennandri Contrarkum Uyundam Uyivillai செய் நன்றி கொன்ற மகற்கு. So it's considered to be a great sin. Like if you don't thank the one who has done good deed to us. So I thank you very much, ma'am, for this wonderful session. I still remember when I was a third year student, I heard your story, how you struggled in your initial practice, and how your Dr. JSR helped you, and still remember, and that was become one of our inspiration. I know many young doctors, female doctors would be you would have served a great inspiration for them. Yes, even young doctors like us. Thank you very much for spending time with us and sharing your knowledge in abundance. I also thank the organizers and the participants who have been patiently listening. And I would like to also mention about the next upcoming session of next Sunday. We have COVID-19 management with specific homeopathic remedies in 20th June by Dr. Nahendra Babu sir, which is going to be an English session from 3 to 5 p.m. And also there's an added session in the regional language by Dr. Sudhakar sir on the topic osteoarthritis and its homeopathic management from 7 to 9 p.m. So hope we meet and learn continuously.
Thank you, everyone.
Thank you very much.